Today we will be taking one more topic of interest, that is drugs used in cardiac ischemia. I have just changed the topic, changed the name, because if we speak only of one word, it does not mean the whole thing. So here, if we use cardiac ischemia, it can be right from acute to chronic. So that's the reason why I have used drugs for cardiac ischemia. Okay, so ischemia can be, it leads from angina to ischemia to infarction. So we can complete all the three. Wherever they are required, you can use it appropriately with rationales, so that you will come to know which is used where, why, how, what, when. So we will be talking on these topics: types of angina pectoris, drugs in angina, and treatment of angina, acute MI, as well as IH. See here, I think this one you have to make it. See, in angina, what happens? The norm here, the lumen is okay, patent lumen is there, normal endothelial function is also there, and platelet aggregation is inhibited. The main problem will be platelet aggregation either, or there will be increased oxygen demand, or the supply will be less. Okay, either there will be a block, vasospasm, or there will be oxygen demand, very high oxygen demand. And third, it will be, the supply will be very less. So in case of acute angina or classical angina, in classical angina, there is a patent lumen, normal endothelial function, platelet aggregation is inhibited, everything is perfect, but the demand is more or the supply is less. So we have to take care of those things. No damage is done. The heart reverses back to physiologically near normal in this condition. In stable angina, the lumen is narrowed by a plaque, that is the atherosclerosis. Platelet aggregation, fat accumulation, all these will take place. Even if vasoconstriction has to take place, it will be inappropriate. It will be inappropriate vasoconstriction. So there is a partial blockade and inappropriate vasoconstriction in stable angina. Whereas in unstable angina, which is like a bomb, platelet plaque will get ruptured at any given time. See here, the difference between these two, the platelet and the thrombus is formed here. This plaque is ruptured, everything is entering into the lumen, platelet aggregation is seen, thrombus formation is seen, and there is unopposed vasoconstriction. Unopposed vasoconstriction is there here, which can result in a bomb, total bomb. Whereas in variant angina, there is a coronary vasospasm, which is also called as Prince-Metal angina. Prince-Metal angina. So these are the ones what we have, and these you should know literally how it occurs and how the clinical symptom signs is, and then appropriately use the drugs, which we will come to in another 1 or 2 slides. Now, a little more between the differences between this unstable angina, non-STEMI and STEMI. STEMI and non-STEMI is mainly by ECG. Okay. This unstable angina, you can to a certain extent make out even by clinical findings. These words are mainly by ECG findings. So the coronary obstruction is partial, which can lead on to complete, but in non-STEMI it is partial, whereas in STEMI it is complete. There is ST elevation. STEMI is ST elevation. Myocardial necrosis is not at all there. So if you recognize early, you can salvage the myocardium. Whereas here, small area of necrosis occurs where we may call it as ischemia, whereas here it is infarction. It is infarction. So you have to know all the three words differently, how to really do it. Biochemical markers, nowadays we do it by troponin T and I, which are cardiac specific, and the others are non-specific enzymes. Here there is no change. It is not at all present. Here it might be present, and here it is absolutely present. So we do troponin T initially. ST segment is always elevated. This is one thing what you should know. You should always keep on the table your normal ECG and the abnormal ECG, and you should know, you should just write down how much difference is PR, how much is P, how much is QRS, everything, and at least able to find out which is normal, which is abnormal. At least if you are able to find out, you can make out that chest pain is due to cardiac, and hence you are done with it. You are saving the patient almost by 90%. If you find out that it is an abnormal ECG. If you do that, that is more than sufficient apart from clinical signs and symptoms. Later on, nowadays, we do this troponin T, where the results are obtained within about 45 to 50 minutes. So you can really find out along with ECG the troponin levels, and then you have to treat accordingly. See, in effort angina, we miss some of these portions. What do we miss actually? See, in chest pain of effort angina, see here, it is from seconds to minutes to hours. What all changes can take place? In effort angina, first there is ischemia, then there is diastolic dysfunction, then systolic dysfunction, then dyspnea, which comprises of ischemic cascade. And the symptoms of pain are at the dyspneic level, whereas ECG changes are already taking place here. So you have to find out the moment the patient is feeling discomfort, no, you have to find out so that you are completely recovering the myocardium. Otherwise, what happens? You do give all these things, pain relief, ECG comes back to normal, systolic recovery also starts, but stunning would have taken place. Cardiac stunning would have taken place, and a partial ischemia or necrosis will take place over a period of time depending on other problems like age and the amount of activity the person would have done. All these will matter. So this has to be recognized where we miss this and see to it that the person goes either for ischemia or infarction. So this has to be recognized and seen to it that the heart comes back to almost near normal physiological function. We cannot say 100% even in our dreams, because only God can do it. We cannot do anything else. Next, here in this line, if it is removed, no. Okay. Now, this ischemic heart disease, the whole scenario is known as ischemic heart disease because ischemia has already occurred. But this is divided into two things. One is chronic coronary artery disease, where it is known as stable angina, and acute. In acute, you have to recognize totally so that it does not go to chronic, or even if it goes chronic, you are giving a good quality of life. So in acute coronary syndrome, as I showed you in the last slide, there is unstable angina, non-ST elevation, that is acute myocardial infarction, and ST elevation, which is more dangerous. This is also myocardial infarction. As I told you, this is shown in only in ECG, that non-ST elevation and ST elevation. So these things should be made out because this constitutes a series of clinical presentation which includes all of them, and the most important where we can have sudden death also in case of ST elevation, where there is formation of thrombus and the platelets getting into the vessel where it is blocking. All those will be the problems what we meet with these things. Now, coming to the drugs. Okay, I have directly come to the drugs rather than enumerating it. All of you know these usually. So I have come to directly the drugs per se actually. So the whole show revolves around nitrates. Why? Because either there is a demand is high or the supply is less, so that there is coronary flow interference, where we should see to it that coronaries are dilated and there is good flow to the whole of the myocardium. So you should choose such a drug where there is very good flow both to the ischemic areas as well as non-ischemic areas. So one of them is also down, then still the problem exists. Why we are bothered more about that problem is it may lead on to various complications, mainly atrial fibrillation. Why? Because the thrombus will get lodged in the atria, and this thrombus, if it gets dislodged at any given time, another bomb can occur. That is, that thrombus can go directly to the brain and cause cerebral thrombosis. So these are the problems which are met And also arrhythmias can result because of improper contraction because part of the muscle is damaged. So you have to see at the right time. By the time angina occurs, if you do the necessary job, the whole cardia is absolutely normal, and so patient can lead a good quality of life even with minimum amount of drugs. Also sometimes they can even stop it looking at the scenario or whatever is the condition like. So the only drug which can increase the blood flow both in the ischemic and non-ischemic areas is nitrates. So these nitrates basically they act through nitric oxide. As all of you know, nitric oxide is physiologically there in our body, especially in the blood vessels. Normally, physical vasodilatation occurs along with beta-2 agonists, and so we are very happy. Now, this is not there, so the coronary dilatation is hampered. So, for that reason, when we give nitrates, where they release nitric oxide, these act on guanylate cyclase, which forms cyclic GMP, and free side this AMP will stimulate, GMP will relax. So the myosin light chain kinase interaction is decreased. Together with that, free cytosolic calcium as well as sarcoplasmic reticulum calcium is decreased, and hence there is relaxation. Once there is vasodilatation, there is free flow of the blood. But basically, this is not as simple as you have seen. Basically, they are venodilators. So once it is a venodilator, what happens? I'll show you here. But initially, you listen. This is a cascade, what I told you in the previous class also. So all nitrates, CCBs, ACE inhibitors, and beta blockers all have these 8 or 10 words in common. But you have to place it at the right place because the initial point is different. Nitrates are venodilators. Okay, right from veins to venules, they dilate. So preload is decreased. Whereas beta blockers, they basically decrease the heart rate and hence the force of contraction. And hence the force of contraction. And then the rest of the things occurs. Whereas with calcium channel blockers, they are arterial vasodilators. So the afterload is decreased. Whereas with ACE inhibitors and ARBs, they are mixed vasodilators along with nitroprusside also. Once they are mixed vasodilators, what happens? Both veins and arteries are dilated. So preload and afterload, both of them decrease. So this is the starting point what you have to realize. Later on, other things what come, you have to streamline, which I have already mentioned in the previous class. Now with nitrates, we will see what best can help. So when nitrates are given sublingually or by orally in chronic angina also, what they do, they are basically venodilators. Vascular smooth muscle relaxation occurs, and hence what happens? The veins are dilated mainly. Once the veins are dilated, preload is decreased. The preload is the volume of the blood entering into the heart is decreased. Once that is decreased, what happens? The left ventricular end diastolic pressure as well as volume is decreased. So heart has good diastolic time. Once the heart has good diastolic time, the cardiac output is decreased, force of contraction is decreased. Once these decreases, as I told you in the last class, the coronary flow is mainly during diastole, whereas for the other parts of the body, it is during systole. Okay, so here, because of all these problems, what happens? Coronary flow is increased. So once coronary flow is increased, both to the ischemic areas as well as non-ischemic areas, what happens? Heart gets a good blood supply, nourishment, and hence there is relief of angina. Relief of angina. This is the first and the foremost drug what you have to think of. As I told you in the other class, for all acute things, you have to act. Whereas for all chronic things, you have to think. Okay, here it is an acute emergency. So you have to see to it that you have to give vascular smooth muscle dilators only, but you have to know which drug to give at what time. So these nitrates are the one which will increase the coronary flow not only to the ischemic areas but also to the non-ischemic areas, by vascular smooth muscle relaxation, nitric oxide release, and after that there is a cascade of events which takes place within a minute, and hence patient gets relief from angina. The patient who was lying down can just get up and even say, yes, my pain is gone, I can just move. But you should not allow them to move because the systole would have decreased to a maximum, and so you have to be careful while doing all these things. Now, what I told you, I have depicted so that it retains with you forever. Okay, so you know that you have seen the diagram, the systemic. You have to mainly, when you give nitrates, it causes dilatation, reduce venous return, dilatation, reduce preload. Okay, and once there is reduced preload, afterwards, after a minute or so, there is reduced afterload also, so that arterioles also dilate, and together with that, when they dilate, venous capacitance vessels will dilate, so that again there is reduced vascular return, venous return, which will decrease the actions on the heart. Once they decrease these actions on the heart, the coronary flow will increase, and hence you get the maximum beneficial effect by giving nitrates. So still to remember still more properly both the mechanisms I have depicted here, so, various nitrates. So before this, I'll just give you a glimpse. You have nitrates which can be given in acute attack of angina as well as chronic angina. In acute, and there are various dosage forms of nitrates. Okay, so in whatever may be, the mechanisms are almost the same. They generate nitric oxide, stimulate guanylate cell release, causes vasodilatation, and hence a cascade of events causing vasodilatation and increasing the coronary flow. But the difference is when we give sublingually, what happens? As a spray, what happens? Transdermal patch, what happens? IV, what happens? As well as the oral forms. So there are different dosage forms of these nitrates, and hence the mechanisms are, in case of isosorbide dinitrate and mononitrate, what is happening? The it enters, dinitrate enters liver. Once it enters liver, first pass metabolism. Once there is first pass metabolism, the amount of drug entering into the systemic circulation is less. So you may not get the maximum benefit if at all the dose is simply altered. So always we prefer isosorbide mononitrate. This is a very, very common Viva question right from the undergraduate level. Why isosorbide mononitrate is preferred to isosorbide dinitrate? Though it get converted to mononitrate, the amount of drug reaching the systemic circulation is less, and hence we cannot say that it acts similar to mononitrate when given in the same dosage form. Okay, so this is the main difference between isosorbide dinitrate and mononitrate. When you give nitroglycerin, what is happening? It releases nitric oxide, which can directly alter the endothelial function, and hence alters the SH group as well as mitochondria, and hence together with that the peroxynitrate is decreased to a maximum extent, which can be stimulated both by nitric oxide as well as angiotensin II in the sarcolemma formation, and hence the GTP which is formed will get converted to cyclic GMP. All are lessened, which lowers calcium both in sarcoplasmic reticulum as well as the cytoplasm. Once lower calcium, always there is a vasodilator. Calcium is a physiological vasoconstrictor along with alpha in the blood vessels. So once there is lower calcium, there is vasodilatation. Suppose we give all these at a time. So there is excess nitrates in the blood, which can release superoxide radicals as well as peroxynitrate, which can cause endothelial dysfunction and hence tolerance. We'll come to that later. Okay, so these are the problems which are met. So you have to know which dosage form should be given at what time, so that you are preventing nitrate tolerance, because nitrates are still the poor man's angioplasty. Poor man's angioplasty. Patients who do not want angioplasty or bypass can still survive. God will make him to survive, but you should really give a push for that. So you have to give nitrates. So you have to know what dosage, form and dose to give so that you are preventing nitrate tolerance. Now this again I have shown you in a little more molecular form where they get denitrated, aldehyde reductase and glutathione transferase is formed, which is almost very minimal in our body. It has to be keep on getting formed in the liver. So if you keep on giving too much, then it results in nitrate tolerance. So these will get converted to nitric oxide, which activates guanylate cyclase, increases cyclic GMP, dephosphorylation of protein kinases will occur, and also together with that parallelly there is free cytosolic calcium. To know this last step, you should know that receptor-mediated drug actions. I told you in the last class also, this you should be remembering often. There are 4 types of receptor-mediated drug action. One is ion channels, that is receptor-mediated ion channels. Example is acetylcholine and DTC at NM receptors, where the action is within seconds. The second one is GPCR. Okay, in that you have got 3 types. One is cyclic AMP GMP, second one is IP3DAG, and third one is voltage gated ion channels, calcium, sodium, potassium, as well as chlorine. The third one is tyrosine kinase and MAP kinase, where it is mainly for insulin, and JAK-STAT pathway for hormones. And the last one is the nuclear receptor, which is mainly for steroids and sex steroids. So this comes under GPCR. In that, cyclic AMP and GMP. Cyclic AMP is always a stimulatory, whereas cyclic GMP is an inhibitory. So this will cause dephosphorylation and hence decreased free cytosolic calcium, which causes smooth muscle relaxation. So as I've been telling you so many times, the dose, route, dosage forms are very, very important. This you have to really remember for anything and everything, right? You can treat the patient even on the road. So to that extent, they are very effective. So you have to know which form of nitrates to be given. So nitroglycerin, when it is given sublingually, it is also known as glyceryl trinitrate, which comes as angiset. So 0.5 milligrams sublingually can be given at an interval of 5 minutes, 3 times. Okay, 3 times, and the duration of action is 15 to 40 minutes. 15 to 40 minutes. And so in that period, you along with this, you give little bit of prophylactic measures and shift them to tertiary hospital so that they are maintained and the person does not land up in ischemia or infarction. Along with nitroglycerin sublingual, we do give aspirin, soluble aspirin or baby aspirin 325 milligrams, clopidogrel of 75 into 4 tablets because dual antiplatelet action. Last one is atorvastatin 80 milligrams. Apart from decreasing the formation of cholesterol by HMG-CoA reductase inhibition, at 80 milligrams, it has got pleiotropic actions. The additional actions are known as pleiotropic actions, where it has got antithrombotic, anti-plaque, anti-plaque, then anti-inflammatory. All these actions are the antioxidant. All these actions are there. So this will really keep the vessels in a perfect form. So for all these things, you have to give these drugs and then send them to tertiary hospital. If the heart rate is above 100 or nearing by 100, give a small dose of metoprolol because this is a sympathomimetic condition. The heart rate would have normally increased. So this is a sympathomimetic indication. Situation where because of sympathomimetic activity, adrenaline is increased, which acts on beta 1, beta 2. So because of that, there may be further vasoconstriction also. So for that reason, you have to give a small dose of metoprolol, say about 12.5 milligrams. Write all this and ask the patient to be in a tertiary hospital within 45 minutes. He will come back home running. So this is the state of affair. If you really see the condition, try to find out the condition and treatment. This nitroglycerin also comes as 5 milligram oral, where the duration of action is 4 to 8 hours. And we also apply it as transdermal patches, that is 2% skin ointment applied as 1 to 2 inches, like Johnson Band-Aid itself. You can apply this nitroglycerin patches. The next one is isosorbate dinitrate. But this we don't use. Dose arbitrate is the one which is given most often. Still, we prefer isosorbate mononitrate because there is the first pass metabolism is very much decreased. Active drug enters the systemic circulation to the maximum extent. So this is once again for a revision, because this drug is very, very important. So I have tried to insist at many places where we don't use the last three. We normally use glyceryl trinitrate in various forms in acute angina, acute infarction. Okay, in all these cases we use these, and lastly we use isosorbate dinitrate, which usually comes as sorbitrate. Next, this is one of the most important drug interaction what you should see, which is quite serious. We have so many adverse effects. The common ones might be because of vasodilatation, hypotension, tachycardia. All these things are there. But the most serious interaction is nowadays because of off-label drugs and people going and buying in the shops as and what they like, because there is no control. So all these has led to these forms of serious drug interaction and adverse drug interaction, which has led to about 3% of deaths in the whole world and the casualty admissions. So these are the problems. So now the serious drug interaction is mainly because of nitrates and sildenafil or phosphodiesterase 5 inhibitors, which are given together normally. The phosphodiesterase inhibitors as such is a short note where you have to write from 1 to 5 everything. But here we are specific about phosphodiesterase 5 inhibitors, which also cause the same type of vasodilatation by the same mechanism as nitrates. So I have depicted in this figure nitrates causing excess of nitric oxide, and this can also act on these penile nerves, liberating GTP, then cyclic GMP. The same thing is with PD inhibitors, which will and this will inhibit the cyclic GMP. Okay, this will inhibit cyclic GMP, causing lot of vasodilatation. This was actually wanted for erection in a normal condition, but when it is excess, it causes major hypotension, syncopal death. This is the problem what we see, and this, even if you don't remember other conditions where we usually see in other or they may be able to find out, but this as a drug history you have to ask without any doubt. More than using as a Viagra or for erectile dysfunction, we also use it for pulmonary hypertension. So you have to be careful in case where the person is also having pulmonary hypertension and then coming with acute angina, and you are more fond of giving nitrates, you have to ask drug history either with the person or with the attender so that you don't cause havoc. So success surgery, but the patient died. These are the problems what we have. And so you should not miss drug history nowadays because of Google searches, patient buying on his own, off-label drugs. All these are the problems which are met. So please be careful in all your personal history, patient history, that history, this history. You ask drug history as the main one. Now, coming to this is a more bigger problem. Most often we have Monday morning sickness as well as nitrate tolerance. So these two are the main ones, and nitrates cause this sort of tolerance because of peroxynitrate, which is in excess, and hence there is tolerance to this drug. What do you mean by tolerance? You need more amount of drug for the same action, and we may not get the beneficiary action even at the higher dose, and hence we do have the adverse effects more than the therapeutic actions. So it is mainly due to endothelial dysfunction. So how does it occur? Nitrates, which on a long term will have this sulfhydryl groups very less, peroxynitrates is formed. So nitrate tolerance is there. So systemic circulation causing the endothelial dysfunction, which causes reflex neurohumoral activation. Once neurohumoral activations are there, adrenaline, angiotensin 2, all these are increased, which further causes vasoconstriction, and there may be rebound angina. There may be rebound angina. So for that reason, you have to be quite careful, and these can be blocked by carvedilol, hydralazine, as well as ACE inhibitors, as well as ACE. You know, no, carvedilol is an alpha plus beta blocker. Hydralazine is a vasodilator. AC inhibitor are mixed vasodilators. They are mixed vasodilators. But in fact, we give combination of nitrates and the hydralazine in case of heart failure for a long-term effect. But still we are afraid because we have got better drugs now, anti-mortality drugs, which we'll be dealing in the next few classes. We have got anti-mortality drugs in cardiac failure. They are mainly either AC inhibitors or ARBs, first line, then beta blockers. Then we have got mineralocorticoid receptor antagonists. They are wonderful drugs which can lead a good quality of life also. The problem with nitrates, as we are seeing, is nitrate tolerance, and the effect might not be good. Hydralazine on a long term can produce tachycardia, volume overload, fluid retention, and also it can cause systemic lupus erythematosus. So these are the problems which are met. So when we have better drugs with good quality of life, better start using that, so that patient, if at all he is a slow learner, he can still go on to do work for next 30 years also, provided we find the patient properly and we put the drugs properly. There are about 10-12 drugs where you have to rotate, but you have to know where to administer at what level, so that you will come to know very nicely when to use which drug, only when there is some stuff and confidence in you. So this can lead on. The next step also can be met with not only hypotension, there can be MI and death when we use nitrates and sildenafil, which is very, very common today. Drug interactions are very common today because of polypharmacy. Because of polypharmacy, these are and prescription errors. The doctor is so busy writing everything, and the patient does not want to reveal the drugs, though we insist. So you should keep on insisting them what sort of drugs do they take, and the doctor should be vigilant about these adverse drug reaction and drug history, so that they are preventing death and also the morbidity level, and hence give the patient a good quality of life rather than the showing the end of life. So coming to the summary, mechanism of action, 4 words. They release nitric oxide, decreases cyclic GMP, causes vasodilatation of vascular smooth muscles. Okay, and then they overall they are venodilators, decrease preload, flow to the heart is decreased, force of contraction is decreased, LVEDP and V both are decreased, cardiac output, force of contraction is decreased, coronary flow is increased, both to the ischemic areas as well as non-ischemic areas. Okay, and then in case of effort angina or classical angina, we use intermittent nitrates to prevent Monday morning sickness as well as nitrate tolerance. We also use in prophylaxis, as I told you, they are poor man's angioplasty. If the patient wants to walk, okay, in the morning, tell him to take a dose of nitrates, sorbitrate, about 10 to 20 milligrams. Go for a walk and come back. He can really be done with that in case of anginal prophylaxis. Unstable angina, only at rest you can give. Don't give when it is a full-fledged thing. And early phases of acute myocardial infarction. And in case of chronic heart failure, we give nitrates with hydralazine whenever there is failure, nocturnal dyspnea, as well as exercise, because of good coronary flow. In acute pulmonary edema also the same mechanism holds good, but the problem is with nitrate tolerance and serious interaction with sildenafil-like agents. But you have to be careful because they are vascular smooth muscle relaxants. They can dilate even the biliary sphincter as well as esophageal sphincter. Hence, they are used in esophageal spasm as well as biliary colic. So, you should know whether the patient is suffering from cardiac ischemia or biliary colic or esophageal spasm. So when you ask the history, you have to differentiate these three, but all these three are relieved by nitrates because they are vascular smooth muscle relaxants. Why do we use these nitrates in biliary colic especially? Previously we were using nitrates and atropine, morphine and atropine. But morphine increases the biliary colic. It increases the pressure. It increases the spasm of the biliary sphincter. And so we used to give atropine, which used to act as antispasmodic. But they had their own problems, central actions. So this is a direct vascular smooth muscle relaxant. So we prefer nitrates both in biliary colic as well as esophageal spasm. Last two, you should remember, you should never forget when and how to administer, and be careful with these PDE5 inhibitors. Now, the other drugs which are used, we have already dealt. I'll just say it how it is useful in which sort of angina. So, you know, all calcium channel blockers, the basic thing what you should know is all calcium channel, the physiological calcium channels are L-type calcium channels in the heart as well as in the blood vessels. In the blood vessels, they cause direct vasodilatation by blocking the L-type calcium channels. So once they cause vasodilatation in the blood vessels, especially in the arteries, the afterload is decreased. So vasodilatation occurs. Venules are not dilated. So preload is not affected. So there might be some amount of edema. Okay, prevenular edema might be there, but mainly it is an afterload, decreases the afterload in the blood vessels right from aorta to the smaller arterioles also. This is the first thing what you should know. Once they decrease, obviously there is reflex tachycardia. Reflex tachycardia. And you should know there are two types of calcium channel blockers. One is DHP and one is non-DHP. Non-DHP like verapamil and diltiazem, they act on the heart L-type calcium channels in the myocytes. So decreased conduction. Here it is dilatation, here it is conduction. Once there is decreased conduction, heart rate will decrease, and most often they are used in arrhythmias and they can lead even to heart block. So you have to be careful. Their drug interactions are very common. Amongst the DHPs, nifedipine was used very commonly, but we are afraid of the vasodilatation and fall in blood pressure. So you have to record the blood pressure before giving nifedipine. So we have switched on to amlodipine and S enantiomer of amlodipine, so that it is also long acting, and we have got a good result also in hypertensive crisis as well as uterine relaxant, and also in maintaining the isolated systolic hypertension. Nimodipine and nicardipine are specific to subarachnoid hemorrhage. Clevidipine is today, as on today, it is the drug of choice in hypertensive crisis. Clinidipine is for diabetic nephropathy. Azlindapine is the latest oral calcium channel blocker, which blocks all the three channels, T, N as well as L type, so that we have got a better benefit compared to the older ones of nifedipine, amlodipine or nimodipine. So these are few things what you have to remember. In angina, we do use along with beta blockers. We are afraid to use all alone. We have to look after the BP and other things. Only then you should you should have it. Especially they cause tachycardia. Already angina is a sympathomimetic condition. This causes further tachycardia and can worsen the situation. So for that reason, DHPs are not used in angina. Okay, so if at all you want to use, you have to use it along with beta blockers, or you can use all the three drugs put together in resistant angina. Verapamil and diltiazem is 50-50. Verapamil mainly on the heart and mainly in arrhythmias we use, never in angina. To an extent, you can use even in hypertension. The congener of verapamil is flunarizine, where we normally use in prophylaxis of migraine, alternative to propranolol, or when propranolol is contraindicated. Because propranolol is contraindicated in A, B, C, D, asthma, block, coronary vasospasm, diabetes, P for not my name, it is peripheral vascular disease. So what is the summary of this? Recollect: arterial vasodilatation, hypotension, reflex tachycardia. Isolated systolic hypertension, which is there most often above 60 years of age. It is contraindicated in acute classical angina, but it is drug of choice in vasospastic to terminate the acute attack of vasospastic angina along with nitrates. Amlodipine is longest acting, oral for essential hypertension and hypertensive urgencies. U for normal, E for end organ damage. Nicardipine, parenterally for hypertensive emergencies, nimodipine for subarachnoid hemorrhage. Nifedipine and nicardipine can also be used for premature labor to decrease the contractions. Nifedipine, felodipine, and diltiazem for Raynaud's phenomenon because they are vasodilatory in nature. So these are a few of the, you have to know about the bioavailability and plasma half-life because we can administer either once or twice daily. Most often they should be administered once daily and they should be administered at night because of decreased edema. The plasma half-life would have been very less. So morning, by the time they get up, there will be only about 75% or 50% of the drug, which can decrease the edema formation. And hence, most of the times we start these calcium channel blockers at night. At night. In acute cases, no problem. But in chronic cases, start at night so that you are getting relieved of many of these adverse effects. And this nifedipine is also known to cause gum hyperplasia. The main drugs causing gum hyperplasia are nifedipine, phenytoin, which is an anti-epileptic drug, and cyclosporin, which was the drug of choice in renal transplantation because of hypertension, seizures, and gum hyperplasia. Now we are using tacrolimus, sirolimus, MMF, mycophenolate meftal. We are using these drugs more commonly than cyclosporin. Now coming to a word about beta blocker. We have dealt enough of beta blockers. A word about beta blockers in angina. What are the two main effects of beta blockers? The moment we talk beta blockers, decreased heart rate. That's the first thing what should come to your mind. Once that comes to your mind, once there is decreased heart rate, obviously decreased cardiac output, decreased force of contraction, decreased force of contraction, but the cardiac output on a long run remains the same. So the only anti-anginal agent shown to prolong life. Why we are using beta blockers? Because it prolongs life in IHD. Mainly in post-myocardial infarction. After the acute phase, when we send the patient home, in the list of drugs, beta blockers should be given because the heart rate will be most often it will be more than 100. But if it is around 60 or below 60, never use beta blockers. Never use beta blockers because just after a week or so, they might land up in casualty because of the adverse event of beta blockers. And here, most often try to use cardio-selective beta blockers or carvedilol rather than others so that you are minimizing the beta-2 effects and hence the adverse effects of beta blockers. It is used for prevention attack but not to relieve acute attack. In acute attack, what is the problem? Either myocardial demand is there or oxygen supply is less. This will not do anything. Okay, only after decreasing the heart rate, force of contraction, cardiac output initially, then there is flow to the coronaries, which by that time the heart would have got damaged and it might go to ischemia also. So for that reason, before acute attack occurs, that means if the patient is obese, hypertensive, diabetic on a long run, and complaining of pain here and there, in such cases, you use it. But if he is suffering already from acute attack of angina, never use initially beta blockers. Only when you are sending to a tertiary hospital, if the heart rate is more than 100, add a very minimum drug that is 12.5 milligrams of Metabolic. It is absolutely contraindicated in variant angina because there is beta 1, though you give beta 1 at higher doses, beta 1 drugs lose their receptor selectivity. They also act on beta 2. So the unopposed vasoconstriction happens and variant angina may go on to further angina and hence it is totally contraindicated. And it is used in prophylaxis of ACS as I told you earlier or unstable angina, and in silent angina it reduces total ischemic time of myocardium per day and on regular use and reduces mortality. This is the only statement where beta blockers will stand the drug of choice in most of the cardiovascular conditions, not per se hypertension or per se angina. Along with other cardiovascular conditions, it holds the major indication or the major role in these cases. So this is the total of the three. So and hence we can treat resistant angina. So where all can we block or where all can we use in combination? Nitrates, as I told you, two words you remember. First is venodilatation, decrease preload. Later on, it is arterial dilatation and decrease afterload. Hence coronary vasodilatation. CCBs, they decrease afterload, arterial dilatation, decreases myocardial infarction, very doubtful. Okay, decrease force of contraction or heart rate, but not to that extent because it should go around and come back. Whereas beta blockers, they block cardiac beta 1 receptors and prevent all the three, thereby decrease all the three, decreasing myocardial oxygen demand and hence increasing the oxygen supply. Now, with these words, you find out that, see, once they decrease preload or afterload, they are bound to cause tachycardia. So, for that reason, don't use nitrates, nicorandil, and CCBs together. Okay, they are contraindicated. Alternatively, you can use beta blockers with nitrates and beta blockers with CCBs. Okay, so there is additive effects, and beta blockers cause bradycardia, whereas the others cause tachycardia, and the additional effects like decreased preload, afterload, or decrease which increases beta blockers increase force of contraction. Together to a time, PP is also maintained to a certain level. So you can combine beta blockers with either of them, but never use nitrates, nicorandil, and CCBs together. All the three can be used in resistant angina. All the three can be used in resistant angina. You make a table: nitrates, preload, tachycardia. Beta blockers, decrease heart rate, increased force of contraction, bradycardia. CCBs, decreases afterload, tachycardia. So all these will combat each action on one another and see to it that angina is reduced in case of, especially in case of resistant angina. Nicorandil is little bit a newer drug which can have both preload and afterload decrease and hence coronary vasodilatation by a mechanism known as it opens up the ATP sensitive potassium channels. So you can't use it with potassium channel blocker. Name a potassium channel blocker which we use commonly. Anybody? Glibenclamide, oral hypoglycemic agents. So you have to be careful. So in such cases, these drugs antagonize each other and they may not give, you may land up in therapeutic failure. So now in total, actions of anti-anginals, the block 1, you see nitrates, calcium channel blockers, how they dilate by reducing preload, afterload, reducing venous return and afterload. Okay, and beta 1 acting through SA node, funny channel currents. Okay, then metabolic agents, that is nicorandil by 10%. Then we have trimetazidine, then ranolazine and ivabradine. All these are known as metabolic agents. All these put together, we have got the total action of anti-anginals. And you have to see in resistant angina, we try to use metabolic agents because they will shift on this fatty acid metabolism to glucose metabolism and hence see that there is a salvage of these myocardium, which is further going for ischemia or infarction. So novel anti-anginal agents, ranolazine, okay, they are mainly inhibitors of fatty acid metabolism. So because of this, they will shift into the glucose metabolism and hence they will lessen the sodium and calcium overload, and also paraxylene will inhibit free fatty acid metabolism at the enzyme level, and trimetazidine will inhibit fatty acid level at the mitochondrial chain level, and hence it will this also can increase insulin sensitivity. So the oral hypoglycemic agents can be reduced if at all there is a choice of this trimetazidine being put by a cardiac person. Okay, IF channel inhibition is mainly by ivabradine, which is a direct heart rate lowering agents. The four main heart rate lowering agents in this world are metoprolol, then we have verapamil, then digoxin, lastly ivabradine. By decreasing heart rate, this also has got inotropic actions, which we will deal with inotropes in the next class. This is also known as ionodilator. This also comes under ionodilator, ivabradine. but mainly it decreases heart rate. So we always try the ivabradine only when metoprolol or other heart rate lowering agents does not decrease the heart rate below 100, then we add this ivabradine. So for example, you would have put metoprolol 50 to 100 milligrams, but the heart rate is about 100, 110, 120. Again, sympathomimetic, more prone for myocardial damage. In such cases, we administer this ivabradine. So this is a small, this one of the novel agents, that is nicorandil, trimetazidine, ranolazine, ivabradine, a direct bradycardiac agents which blocks funny cation channels, hence used in inappropriate sinus tachycardia mainly, also used in chronic stable angina. This last dipyridamole is a notorious drug, though it is a very good antiplatelet and also a vasodilator. It only distributes the blood flow to the non-ischemic areas than the ischemic areas. But here we want mainly in the ischemic areas. So dipyridamole causes coronary steal phenomenon. So we dare not use this dipyridamole in case of this acute attack of angina. Nowadays, we directly go on to drug-eluting stents, that is sirolimus, everolimus, zotarlolimus, as well as paclitaxel. Paclitaxel. There is a spelling mistake. It is paclitaxel. So they are all immunosuppressives, and hence they will most often prevent restenosis, and hence the longevity will be good along with the maintenance drugs. Now coming in toto, what are the pharmacotherapy of angina, acute MI, and IHT? Now in exertional angina, we use sublingual nitroglycerin. In acute attack, sublingual nitroglycerin. Prophylaxis also same, but till 30 minutes we can use. In chronic prophylaxis, long-term, long-acting nitrates or beta blockers or calcium channel blockers orally. If one is not sufficient, then combine, but never combine nitrates with calcium channel blockers. In severe angina or resistant angina, you can combine nitrates with beta blockers, nifedipine with beta blockers, never nitrates with CCBs, and CCBs with beta blockers and nitrates in resistant angina. Vasospastic angina, nitroglycerin or nifedipine can be used, never use beta blockers. Even in your dreams, you should say beta blockers are contraindicated in vasospastic angina or principal angina or anybody knows? What's the other name? Principal angina, vasospastic angina, and find out. Next, in unstable angina, most often there is sudden death or hospitalization. Most often it occurs at rest, prolonged attacks, angina after MI. Again, one more angina after MI. In these, you have to give all these drugs. And so you have to be careful about all these should be given. Heparin IV, okay? Then CCBs, when you are giving beta blockers, don't give along with nitrates. Then this is the drug of choice because we are suspecting the thrombosis. So we use either abciximab or eptifibatide in these cases, or eptifibatide or abciximab is the drug of choice, which we use it as GP receptor antagonist, which is the last step in inhibition of the platelet aggregation. And in MI, we have got both immediate treatment and long-term treatment. Immediate is acute MI, long-term is treatment of IHT. So this is the various things what undergoes whenever the patient undergoes and has ischemia, not angina. In angina, everything is still normal. The only thing is heart is warning that I am going to die, save me. Whereas in ischemia, it is almost dying, not total dying, which is infarction. It is almost dying, but definitely there will be cardiac pain where we give morphine, morphine relieves pain by 4 methods. One is it acts as a mu agonist. So it is the opioid analgesic central mu agonist. By this, when we give IV, it decreases anxiety and apprehension. Then it produces sleep. makes the patient indifferent to the surroundings and hence relieves pain. Okay. Normally, this anxiety and apprehension will stimulate the sympathetics. If it is above 100, give beta blockers. Okay, which can increase cardiac work and cardiac efficiency. So because of this, it can increase arrhythmias. So for this, you use any of the vasodilators, that is nitrates, CCBs. If at all you have got any IV AC inhibitors or ARBs, you can use this, or any injectable vasodilators like hydralazine, diazoxide, or sodium nitroprusside. All these can worsen in myocardial ischemia. So for that, you use fibrinolytics to see that there is patency. Give oxygen because oxygen supply is very less, so that you are ultimately preventing infarction and cell death. Infarction and cell death. So here again, this whole thing you remember, you can remember the whole, everything of today's you can remember in this slide completely. So see here, chronic coronary disease, stable angina, acute. In chronic, these are all the drugs which are used. These are all 100% you should use. Aspirin, 150 milligrams. Beta 2 antagonist, preferably metoprolol or carvedilol, because it has got additional antioxidant activity and vasodilator activity. Nitrates, because venodilator, coronary flow is increased. Calcium channel blockers, if at all BP is very high, especially systolic. AC inhibitors has decreased the use of all these because it is a mixed vasodilator. Not only decreases BP, it also decreases remodeling, fibrosis, and apoptosis. When these are quite resistant, we switch on to ranolazine or trimetazidine because they are metabolic agents and also increase the insulin sensitivity. So this is a standard treatment of any chronic heart disease. In acute, we are more bothered about this than this. Here, you start with nitrates actually, but aspirin, beta 1 antagonist, as I told you. But in addition, you should add clopidogrel as well as atorvastatin. Then you differentiate between ST elevation and non-ST elevation. So in ST elevation, direct thrombolysis. Okay, either most often we used to use streptokinase, but we can't use streptokinase before 6 months because of the antibodies. It is obtained from beta hemolytic streptococci. So within 6 months, you can't use a second dose. And when we use it, you have to use it in very high levels, and that may cause bleeding and hypotension. All of them cause, but this causes much more so. So because of these reasons, now we have started using altiplase. If this is not sufficient, then we add heparin, that is unfractionized heparin, because low molecular weight heparin, most often it's given subcutaneously, and clopidogrel. But nowadays we have changed it to prasugrel. Because it is totally an irreversible inhibitor. That is the reason why you have shifted to prasugrel. And if at all the patient is undergoing angioplasty, then we can add heparin and or this GP2B3 antagonist, as I told you, apixaban, eptifibatide. Any of these can be added along with that instead of clopidogrel, prasugrel. After this acute event is over, we go for post-myocardial infarction management, where along with that we add statin, AC inhibitor, aldosterone receptor antagonist, the most often spironolactone. Nowadays we have got a specific antagonist which decreases the adverse effects, that is gynecomastia, all these effects are decreased. So we use eprillinone, which will decrease the fibrosis, remodeling also. So these are the main things what we need, and hence we use in this format. You are supposed to counsel the patient why so many drugs are given, and this prasugrel and aspirin are given for 1 year. So restenosis formation is very much decreased compared to clopidogrel and aspirin. So for that reason, first year we normally use prasugrel with aspirin. Now, what is the post myocardial infarction management? A, B, C, D, E. Can you find out? A, B, C, D, E. Aspirin, beta blockers. Okay. Then you have other drugs. Then D for diet. Then E for exercise. So all these should be included in this so that you are effectively managing this and giving a good quality of life. So what are the clinical pearls in angina? You should assess for coronary heart disease. In addition, look for anemia and hyperthyroidism, which can cause angina. And also in alcohol addicts, antiplatelet agents should be lifelong. Beta blockers and CCBs are the mainstay. Nitrates only in exertional and unstable angina. Diltiazem in Prince-Metal angina, as nitrates are very weak arteriolar vasodilators. They get depressed psychologically. So meditation, yoga, and counseling are a must. Now, a small test, 2 minutes. Okay. Mark the wrong statement. Acute attack of angina, sublingual, isosorbide dinitrate. You see the route of administration and the drugs. Sublingual, isosorbide dinitrate. Acute MI, IM, morphine. Variant angina, IV, labetalol. Prophylaxis of angina, oral, verapamil. What is wrong in this? It is IV, labetalol. IV, labetalol is the one which is the wrong answer. Now, all are wrong except verapamil with atenolol. Atenolol is no more used. We are using metoprolol or carvedilol. Okay. So, in prophylaxis angina, then atenolol, again, metoprolol in Prince-Metal angina, nifedipine to terminate the attack of acute exertional, GTN in emergency heart failure. Which is wrong? Which is wrong? Atenolol or beta blockers in Prince-Metal angina, because unopposed vasoconstriction and they will further increase the coronary vasospasm. Even if you use beta-1 selective agents at higher levels, they lose the receptor selectivity, so they can cause further vasospasm. Next, which of the following classical angina is correct? Ranolazine, fatty acid oxidation, trimetazidine, bradycardia, aliskiren inhibits breakdown of bradykinin, ivabradine inhibits fatty acid oxidation in myocardium. Which one? First one. Ranolazine. Okay. Next. That's the one. And I think I have done with my slides. Hello.
Excellent class, madam. Excellent.
I
Extraordinary.
have finished.
Extraordinary class, madam. Excellent.
Sir, little more louder. 1 minute. I think I'll take out this so that I can hear you. 1 minute. Yes, sir.
Chinmay, how was the class?